Hello, everyone. It's a great pleasure to be with you here in this short highlight of today's session. This is a highlight of the session on acute coronary syndrome and mechanical complications after a myocardial infarction. My name is Hatem Soliman. I work as an intensivist in London in the UK, and I'm really delighted to have with me today a great friend and colleague, Dr. Marina Clément, a cardiac surgeon from Paris, France. Hello, Marina.
Hello.
So we will have a chat about some of the things discussed in the session. My first question to you, Marina, is about operation. So without operation, what is the survival of these patients?
Unfortunately, without surgery, the mortality is close to 100%.
Okay, so it's very vital to consider closure of the VSD to improve survival in these patients.
And I have another question for you. What is the place of IABP, this kind of patient?
So balloon pump actually still has a role by the guidelines, still recommended as a class 2A, level of evidence C. So it's recommended and it's more useful in the early stages of shock, because when the patient becomes in worsening severe shock and multi-organ failure, the flow of the balloon pump becomes less adequate. But certainly balloon pump has an important role.
And if it's not enough, what else can we propose to the patient?
Absolutely. So balloon pump provides a minimal amount of support, about 0.5 to a liter maximally. And if it's not enough, we will need to consider larger amount of support in the form of microaxial flow pumps or ECMO, preferably ECMO.
Okay. And do you think that in this kind of patient we can let the ECMO alone or not?
That's a great question. We know that peripheral V ECMO increases LV afterload, so it could potentially worsen shunt by increasing the LV EDP. So it's very important to consider unloading along with the V ECMO, whether via the balloon pump or via the microaxial flow pump. So what about surgery, Marina? Tell me, when would you refer the patient for surgery?
So the experience of the surgeon and of the team is really important, and results can be totally different between experienced team or not. So we never have to hesitate to refer the patient. If the patient is not in a spoke center, we have to stabilize the patient first with IABP, for example, and to refer in a center where the patient will find a shock team and all the devices he will probably need. It means the ECMO or impeller.
Perfect.
This kind.
And the timing of surgery, what's your take on that?
Timing of surgery is a delicate question, but I think we know as surgeons that when we operate the patient very quickly, it's not a good idea, because tissues are really fragile, and it's as we are sewing into butter. You see what I mean?
Absolutely.
So
Friable tissue.
Friable tissues. So we have to wait for fibrosis, and at least 7 days, and fibrosis will allow to have better tissues, and we will have a better repair, of course.
Perfect. So that was great. We invite everyone to watch our session. And if you want to watch the session, go to IHF website. The session will be available very soon.